Good morning, everyone, and thank you, Dr. Chow. So today I'll be talking to you about neoadjuvant immunotherapy. This topic we could probably talk about it all day, and there have been talks about it in symposiums past, but it's particularly interesting this year because we've had two big clinical trials published in 2023 and 2024 that have really made this treatment approach more common. So I'm going to go through and define neoadjuvant immunotherapy for you, talk about the history of melanoma and immunotherapy in general, talk about our rationale for neoadjuvant immunotherapy, cover the two big trials, and then talk about some future directions and exciting research initiatives on our end. So what is neoadjuvant therapy? It's a general term. It refers to preoperative treatment, so medication given before surgery. It can apply to chemotherapy, it can apply to immunotherapy, and it differs from adjuvant treatment, which I think we mentioned earlier today. This is post-operative treatment that's given after a tumor has been removed. And historically, we've used neoadjuvant chemotherapy in other tumor types, particularly breast cancer. And the rationale there was giving chemotherapy before a surgery could make the tumor smaller and lead to a less invasive surgery. But immunotherapy or neoadjuvant immunotherapy, and particularly in melanoma, it's a little bit different and the rationale is a little different. So I will try to explain that. And to do that, we have to rewind to 2011 when we started getting approvals for immunotherapy in melanoma. As it's also been mentioned today, historically, melanoma does not respond well to chemotherapy. We had pretty dismal outcomes in metastatic disease back in the 90s and early 2000s. And with the advent of these immunotherapies, we've had people live longer, and we've been able to confer no evidence of disease and have patients not progress for years. And these drugs are drugs you may have all heard of. So ipilimumab, the brand name for that is Yervoy, or ipilimumab and nivolumab, which is Yervoy Opdivo, pembrolizumab, that's Keytruda, and then most recently nivolumab and relatlimab, which is Opdualag. But despite making all of these advances in metastatic melanoma, we know that there's a subset of earlier stage melanomas, like stage 3 melanomas, that are high risk for recurrence, meaning you can take it out and there might be some micrometastatic disease or cells hiding in the bushes, if you will. And these aren't things we can detect by looking at an image or on your exam, but they might be floating in your body, and over time, they can develop into metastatic disease. And I don't want this to be misleading, this image. The figure is undergoing surgery, and that's not the tumor spreading after surgery or anything. That's just probably disease that was there. And we want to develop ways to prevent melanoma from spreading and becoming metastatic over time. And that's where adjuvant therapy comes in. There were approvals in maybe 5 or 6 years ago, starting 2017, to reduce the risk of recurrence by giving adjuvant therapy. So the premise here would be you would do surgery and then you would target that micrometastatic disease by giving 1 year of a treatment after that. And so, as I mentioned, we've had concurrent approvals for that setting. Specifically, the Checkmate 238 trial approved Opdivo or nivolumab for this indication, and then the Keynote 054 trial approved pembrolizumab or Keytruda. There have also been some approvals in the stage 2 setting, but that's a little bit outside of our scope, so I won't go into it. But despite conferring advantages in what we call recurrence-free survival, meaning reducing the risk of it coming back, we haven't yet shown that patients are living longer. We haven't seen an overall survival. And so there still remains the question of how can we optimize these therapies to give a bigger advantage. And I actually really like Dr. Tran's image of how immunotherapy works, but this is the image I have, and we can talk about this for hours, but I'll briefly go over how immunotherapy works. And it all lies in your immune system's ability to detect a melanoma tumor as self or foreign. And because tumors have these mechanisms that can help evade the immune system, they can grow and evolve. And what immunotherapy does is it kind of interferes there and allows the immune system to detect the tumor as a foreign entity and then launch an appropriate immune response to fight it. So it's not like chemotherapy in the sense that it doesn't go in there and just kill all the good cells and bad cells, but it leverages your own immune system to fight the cancer. And so the idea behind giving immunotherapy before surgery in a neoadjuvant fashion is to leverage that. So if we give immunotherapy while the bulk of the tumor is in place and in the body, we're providing a larger blueprint or bulk of the tumor for an appropriate immune system to launch. And so then when the surgeons, Dr. Tran and Dr. Yamamoto, my colleagues, they go in and they take out the tumor, we still have those activated diverse T cells that have that memory and can exert a response that's sustained in a patient's body. And so this is kind of the paradigm shift that we're seeing, that we will identify a tumor, and these are stage 3 tumors, so tumors that we can see have already spread to the lymph nodes, and we can give immunotherapy and then do the surgery, but now we already have that immune response that's launched in the body, and it can continue to exert an effect. And so it's more than neoadjuvant chemotherapy that I mentioned earlier, because the purpose is twofold. It will leverage the immune system to have a more robust and sustained immune response, and it can also reduce the size of a tumor prior to surgery. And as I mentioned, we've had 2 big trials come out, the SWOG S1801 trial and the NADINA trial, which have given us the best evidence thus far of this treatment approach. Both of these trials were published in the New England Journal of Medicine in 2023 and 2024. So I'll first go over the SWOG S1801 trial, and this was a phase 2 trial that enrolled 313 patients with clinically detectable stage 3 disease. So to clarify again, these are patients where we have exam or radiographic evidence that the melanoma, biopsy-confirmed melanoma, has spread to a lymph node. This is not the group of patients where you've taken out the tumor and done a sentinel lymph node biopsy that's shown a tiny drop of melanoma in a tumor. We can easily visualize this. And half of these patients received standard of care treatment in which they underwent surgery and then received 18 cycles, or about a year, of Keytruda afterwards. And the other half of patients, they received 3 cycles of the Keytruda before surgery. Then they received their surgery, and then they continued treatment after. And the researchers measured something called event-free survival as their primary endpoint. So event-free survival means surviving without the disease coming back, the disease progressing before surgery, dying of any cause, or having a toxic effect that precludes the surgery. And the results were quite striking. So at the 2-year mark, the event-free survival in the neoadjuvant adjuvant group, so patients who got it before surgery, was 72% versus 49% in the group that only got it after surgery. And that's reflected in the curves here. So that blue line is the patients who got the surgery or the treatment before surgery, and they had better outcomes than the ones who only got it after surgery. And then this other chart here shows that the tumor size decreasing. So the group over here, closer, or right here on the objective response, where it says these are the patients who had a decrease in the size of their tumor, and then the other half is the ones who stayed stable or got bigger. And this doesn't necessarily correlate exactly with the outcomes we're seeing at the 2-year mark. So that kind of tells you that it's not only about shrinking the tumor, but about having that immune response. And so the NADINA trial was similar, but designed in a little bit more of a complicated way. So this is a phase 3 trial. It enrolled 412 patients, again, with clinically detectable stage 3 melanoma. Half of them got standard of care treatment in which they underwent surgery and then got 1 year of nivolumab, which is Opdivo. And the other group, the experimental arm, they got 2 cycles of Yervoy Opdivo, and then they got surgery. And then what was different and unique about this trial is that the treatment after surgery was very much tailored to 2 things. One, did the patient have a good response? That means if there was no evidence of tumor or very little tumor, what we call a complete response or a major pathologic response, these patients were just observed. They underwent no further therapy for the year after their surgery. However, if these patients only had a partial response or a non-response, then it depended on their BRAF mutation status. This is a mutation that half of melanoma patients harbor. And if they had the mutation, they got targeted treatment. And without any mutation, there was the 1 year of Opdivo as we've been getting for a standard of care before. So again, they measured event-free survival as their primary endpoint. And their results were also quite striking at the 1 year mark. There was an event-free survival of 83.7% in the neoadjuvant combination group and 57.2% in the adjuvant group. And that's again reflected by the blue line is the neoadjuvant Yervoy Opdivo group. And the red line are those patients who got surgery first and then the adjuvant therapy. So again, the patients who are doing well at the 1 year mark, it's substantially higher with the neoadjuvant treatment. And so which one do we use? Is it better for a patient to get the Keytruda, Perswag S1801, or Nadina with Yervoy Opdivo? And really, this is a conversation between your melanoma team, which will be your medical oncologist and your surgeon. But there are a few differences between the two that I'd like to go over. One is that with the Keytruda group, there was a 21% pathologic complete response, meaning we didn't see the tumor at the time of surgery, whereas with the Nadina, the Yervoy Opdivo, 47.2% complete response. And then everybody asks, why would I wait to get my surgery if that's going to cure me? What if I start getting this immunotherapy and my tumor progresses? And what the trials found was that with Keytruda, there was a 9% progression rate, and with Nadina, 2%. So different numbers, but still pretty good. And I think the biggest thing when we're choosing comes down to toxicity. So Dr. Tran mentioned that, the side effects of immunotherapy are much different than chemotherapy, but as many people in this room may be familiar with, they can be quite significant. You can get immune-mediated side effects, which means there's collateral damage of activating your immune system that can attack other parts of your body. And that is more prevalent with the Ipi-Nivo. So the grade 3 toxicity, which is what we refer to when we talk about significant side effects, it was up to about 30% in the Nadina trial with the Ipi-Nivo and 12% in the single agent Keytruda group. There's some differences in how we administer them too. The Keytruda is for 3 cycles. So you get it for about 9 weeks before your surgery, whereas with the Ipi-Nivo or the Yervoy Opdivo, you get it for 6 weeks. It's 2 doses every 3 weeks. And then the adjuvant schedule, the post-operative schedule, of course, differs. Everyone who gets the Keytruda before and after surgery. But with the Nadina trial, it's possible to not do that post-operative therapy, although I know a lot of us are still wondering if we need longer-term outcomes to really make that decision. And then one of the trials actually did involve patients, SWOG 1801, some patients who had stage 4 disease, so more spread out melanoma, but you could take it out. So it's all very exciting, but there are a lot of future directions and a lot of questions that we still have. One, we want to identify prognostic biomarkers. These are things that we can detect in the blood or in tumors to decide who does respond to treatment and who is the best candidate for this treatment approach and who's going to progress or have downstream poor outcomes. We want to optimize the number of neoadjuvant treatments we give and really define whether it's okay to tailor treatments in that post-operative setting. We have yet to establish the survival benefit and really know if people are living longer. And lastly, we're exploring something called the role of therapeutic lymph node dissection. And this is kind of what, this is a trial schema from an older proof of concept study in which called the Prado trial, in which patients with stage 3B and C melanoma received neoadjuvant Yervoy Opdivo. And then the researchers just tested a pre-identified and marked lymph node with the largest metastases. And if there was no evidence of significant disease there, they decided to not undergo the more intensive surgery of taking out all their lymph nodes. And they found that on a 2-year scale, these patients still had a really good recurrence-free outcome, upward of 90%. So that's where we're excited here at ECI to focus our next set of research efforts. And with that, I'll end. Thank you all for listening, and I'd like to thank all of my colleagues here.